So good evening to session number 5 of Mini Medical School South. My name is Tim Gibbs. I'm joined by co-host Christine Handley for the Sussex County Health Coalition. You all know the drill. Here's our social media. By now, you surely know all about the program and the program goals. Housekeeping tips, just to remind people that you put your questions into the Q&A. We'll answer some of them by typing answers along the way. Others we will leave for our presenter this evening to answer at the end of his presentation. Christy has told you several times in the past about the Sussex County Health Coalition, so I think we're good there, and we're going to move past the Delaware Youth Medical Academy. I was just telling the presenter that more and more of you are qualifying for the Youth Medical Academy. You're making up those sessions from prior series, so that's great. All you need to do is we'll contact you, let you know that you now have enough sessions under your belt that you qualify to write the paper to join the Medical Academy, and we'll go from there. To this evening, we are with Dr. Jordan Weisman, Managed Care Behavioral Health Interventions, and I'll turn it over to Christy Handley to introduce him.
Great, thank you, Tim, and welcome, Dr. Weisman. We really appreciate you spending some time with us today and kind of letting the group know exactly what it is that you do and how you got there. So I'm going to do a brief introduction, and we will have this slide deck available so you all can read Dr. Weisman's full bio. I'm just going to go through the highlights, and if there's anything I missed, please feel free to throw it in there, Dr. Weisman. So Jordan Weisman is the Behavioral Health Chief Medical Officer for AmeriHealth Caritas, Delaware. He's responsible for overseeing the clinical policies, clinical programs, and quality initiatives related to behavioral health, and partnering with the Physical Health Chief Medical Officer and market pharmacist to implement integrated care. Prior to joining AmeriHealth Caritas, Delaware, he held senior positions with national behavioral health organizations, overseeing the implementation of evidence-based treatment in correctional and reentry facilities, as well as residential treatment and outpatient centers. He has worked in both inpatient and outpatient settings, providing facility-based individual and group therapies and community-based therapeutic services to clients spanning the life continuum. He has taught for Rowan University Department of Graduate Psychology as well. He received his doctoral degree in clinical psychology from the Philadelphia College of Osteopathic Medicine, PCOM, a master's degree in clinical psychology from PCOM, and a Master's of Arts degree in counseling psychology from LaSalle University. He's a member of the American Psychological Association, American Society of Addiction Medicine, the Delaware Psychological Association, and a fellow of the Pennsylvania Psychological Association. He holds certifications in cognitive behavioral therapy, Lean Six Sigma, and the NIATICS Behavioral Health Process Improvement Strategy. I probably said that wrong, but I'm sorry. His research interests include the assessment and implementation of empirically validated treatment protocols. He is a licensed clinical psychologist in Delaware, Pennsylvania, Florida, and New Jersey. Dr. Weisman, thank you again, and we're going to turn it over to you.
It's good to see a fellow Lean Six Sigma in the group.
Excellent. I'm impressed. We'll have to talk later.
Yes,
I cannot believe that over 100 of you have chosen to listen to somebody who works for an insurance company on this beautiful day. So I thank you. I am going to attempt to share my screen. I may require some assistance to do that. Luckily for you, I only have 20 slides. So I don't intend, or I'm going to do my best to not bore you incredibly throughout the evening. And let's see, from the beginning. Let's go. All right, Christy, help me out here.
The bottom right.
So exit out of this, right. So exit out of this and go to the bottom right, go to, yep, this guy right here.
Yep. Should do it for you.
It didn't do it for me, did it? What did it do for you? Oh, nope. So that will allow me to, I present a view. All good?
There you go.
There you go.
All right. So thank you very much for attending today. It is gorgeous out. I will do my best not to put you to sleep. I'm going to tell you a little bit about what I do as a behavioral health chief medical officer. We will have some disclosures. You actually see in front of you now, this is the agenda of what we're going to cover today. I'm going to have some disclosures first, because the one thing at AmeriHealth we have lots of is attorneys. We have buildings and buildings of attorneys. So I'm going to go through some disclosures first and tell you my exciting life story, where you all look like the pictures on the screen right now. You're going to go, wow, this is incredibly boring. But I will tell you that exciting life story. One of the things I will talk about is, who is my client? Who do I work with? Who do I work with on a daily basis? Where is my allegiance? Things such as that. And there's a question mark there. So we'll talk a little bit about that. And then we'll talk about my role working for AmeriHealth. I have to tell you who and what is AmeriHealth. So I will do that, kind of explaining what is a managed care organization and what specifically does the Chief Medical Officer of Behavioral Health do for them. We will talk about real life interventions. I can work with spreadsheets in Excel. I'm not very good at it, but I don't typically work with numbers and things like that. I actually do behavioral health interventions that affect populations, large groups of people. So we're going to talk about the opioid epidemic in Delaware and what we can do to maybe keep people alive. I'm going to again talk about some real life interventions, those children, things we've done with children, and some conferences we've put on. Talk about some ethical issues. We'll probably not talk about football. And then I will end with any questions you may have if anybody is still awake. That would be the goal. So some disclaimers, some disclosures. I use profanity. I will do my best not to. I'm sorry. There's the apology. There will be topics discussed and real life examples provided. These might be unsettling. I don't mean to present these topics for shock value, because, aha, that was exciting. Wow, I can't believe he said that. But to provide a real glimpse into my professional world. My personal life, as I know, is probably more disturbing. But again, I don't mean to shock you if we do talk about something that is unsettling, especially in today's climate. That is not the goal. If we do talk about clinical samples, and I give you specific examples, I can tell you confidently that the names that I use are not the correct names of the people that I've worked with. We call that redacting. So there are no specific names. Even if I say, well, Jane from Georgetown, Jane was not from Georgetown. She was from another town entirely. So I will do my best to change information so that no personal information is disclosed. You may have heard the term HIPAA. Some of you may be very, very familiar with HIPAA, some not. I live in a world of constantly looking at HIPAA. HIPAA is the Health Insurance Privacy Act, and it specifically allows us to share some information and not other bits of information. People mistakenly believe that all of your health information stays with your doctor. Well, it doesn't. Again, I work for a managed care organization, and we pay that doctor to provide you services. So we are entitled to specific bits of information about your health. And that's very still protected. And we have a lot of things we need to do to protect that information. But again, certain health information about you is shared with others. Sometimes stories that we talk about may be similar to your personal experience. Remember that if you see a psychologist or a therapist personally, you have an agreement with that clinician that anything you say in that office stays between the two of you. That's actually a law that is built into our licensure laws, that we as licensed clinicians, social workers, psychologists, therapists, cannot share what you say in the session. However, during today's lecture, there is no therapeutic relationship. So in other words, if you share something personal, please remember that anybody here can share that. This is a public venue. So I give you very strong caution about sharing personal information. And lastly, I tend to babble. Tim has luckily given me his gracious agreement to give me a 10-minute warning. I will note that I go by Jordan. I appreciate the Dr. Weisman. I don't use the Dr. Weisman. I do go by Jordan. So if you are taken off mute at any time, please, I go by Jordan. So I am the Behavioral Chief Medical Officer of AmeriHealth Caritas, Delaware. The contents of this discussion, this training, were not influenced in any way by my employment. In other words, they didn't tell me what to say or what not to say. I'm not aware that I have any conflict of interest to be here today, and I have no financial agreement that has influenced what I'm about to tell you. I'm happy to develop a nice financial agreement with somebody, preferably near the ocean. That would be fine by me. But there are no conflicts of interest. Again, the contents of today's discussion was not directed by somebody else. A little bit about me to really get you comfy and ready for sleep. So I got my bachelor's degree actually at Dickinson College, a tiny school in Carlisle, Pennsylvania. I actually really did at one time, I'm very embarrassed to say this, push over a cow. They call it cow tipping. I am very embarrassed to say I did that. It's a horrible thing. Don't ever do it. When the cow falls over, it makes a terrible noise. It kind of grunts, and then people are like, "Oh, what did you do then?" Well, then you run because the cow gets up and chases you. So I did, I did go to school in Carlisle. After that, I worked in an inpatient psychiatric hospital right outside of Philadelphia, Pennsylvania. There, I was exposed to seeing real forms of psychopathology, people with bipolar disorder or schizophrenia, major depressive disorder, people with attempted suicide, severe trauma. And I worked with them for several years. And then from that unit, I went to the cardiac unit where I worked with people who were having open heart surgery. And if you're going, well, what does somebody with behavioral health do there? Well, that can be a trauma for certain people and really affects their life. We know that after surgery, especially cardiac surgery, if you don't take your medication, if you don't change your lifestyle, you will most likely fall ill again and potentially die. So you need to make major changes to your lifestyle, and that is behavioral health. So I did that for a while, and after that, I got my master's degree and began working with children. Um, the kids I worked with engaged in behaviors that put them at severe risk of being removed from their home or school. These were kids that used profanity toward their parents or teachers, would strike and fight their parents or their teachers. Um, they would occasionally light fires. They would engage in more aggressive behavior, at times with weapons, sometimes inappropriate sexualized behaviors. And I became very interested in working with people who engaged in these kinds of extreme forms of behaviors. So again, got my master's degree, and from there began working for a forensic agency in Center City, Philadelphia, specializing in children and adolescents that committed murder, rape, or arson. I did this for 10 to 12 years, and then had a subspecialty in working with children and adolescents who were on the autism spectrum that engage in sexualized behaviors. During this time of working with them, I did evaluations and eventually became appointed by the court to do evaluations to determine should somebody be adjudicated as a child or as an adult, or what is the most best treatment for them. Did that for quite some time as I was getting my doctorate. And then after I did that, I worked for a major forensic prison system across the country, ensuring that the prisoners were getting what we call evidence-based treatment that we know science says works. I did that for 5 years, traveled across the country, implementing something called trauma-informed care, and actually was one of the pioneers of trauma-informed care, recognizing the importance of how trauma affects people across their lives. Did that for several years, and then got hired by AmeriHealth, going, why do I want to work for an insurance company behind a desk or in a cubicle with spreadsheets? That sounds terrible. Took that job, and they asked me to make sure that the citizens of Delaware that we work with, about 100,000 of them, were getting treatment that we know works. So AmeriHealth Caritas Delaware is an insurance company that oversees the Medicaid plan for the state of Delaware. We have at any given time about 100,000, we call them members, in Delaware. And I oversee, as I said, behavioral health. When I say oversee behavioral health, we no longer see people as, oh, that's a behavioral health problem, or he's got this diagnosis and that's a substance use disorder problem, or she's got appendicitis, that's a physical health problem. We don't view people like that anymore. We view them holistically. We view them as a person that has behavioral health, physical health, socioeconomic issues, family issues, religious issues. We look at that whole person to see how can we help that whole person do better. Do they need more education? Do they have enough food in the refrigerator? So again, it's no longer sitting and going, well, we're going to reduce this symptom. We look at that whole person. And that's what I've been doing now for the last 6 years in Delaware. I'm going to go through some of those things that I do on a daily basis, but I can tell you, and I'm going to give you some examples, I work with lots of different people because we're not just addressing behavioral health, we're addressing health. So you see that last sentence there, Tim did mention, no, people cannot interrupt. We're going to save questions to the end. Okay, I get that. But again, I don't mind being interrupted. I know he's hating me for saying that. It makes for a more interesting hour. So the role of the behavioral chief medical officer for an insurance company. Who is my client? Who do I work for? So first of all, we are contracted by the state of Delaware. They signed our contract with us in 2017. We started January 1st of 2018. And that's when I began officially working in the state of Delaware. Our office is in Newark. I get to watch the helicopters land at Christiana Hospital. Although, as many will tell you, I have an affinity for Sussex County. I love getting to Sussex County, try to spend as much time as I can in Sussex and Kent. But nonetheless, our contract is with the state of Delaware. So what I'm supposed to do is to make sure that the state citizens get the mental health and substance abuse services they need. That's what I'm supposed to do. And we're not in the business of denying services. That's not good business. We need to make sure people get the services they need, not, well, let's hold it back from them and make money. If they get the services they need, they will be healthier. Yes, I have to stay within the budget. Although we are contracted with the state of Delaware has budgets, and they are very careful with those budgets, and they tell us we need to stay within the budget. If we don't, it's okay. I can tell you, as I've worked with several other states, Delaware is amazing when you say, I have this idea and it's going to help this group of people. They do what they need to do to help people. It's amazing working with some of our government partners. They're very good with that. I apologize, change in weather. I do get dry, so I'm going to take a quick sip of water. I'm very sorry. In Delaware, everybody knows the governor, and everybody seems to have the governor's number. We don't want people to call the governor. When the governor gets a call, the governor calls us. We don't want that. So we do try to avoid crises. I apologize. Okay. And lastly, when I started in 2018, Governor Carney said, we have an opioid problem in Delaware. Can you fix it? Okay, that's going to be a challenge. At the time in 2019, the United States had an opioid problem, and that opioid problem continues today. Heroin, fentanyl are rampant across the country. What can we do? In 2019, Delaware was second in the country for deaths from opiates. We were asked to help change that. It's a challenge. So, who's my client? The state of Delaware. Well, what about my company? I mean, that's who I kind of work for. And they are a for-profit and they want us to make money. But how do we do that? Well, one way we do that is to make sure the members get the services they need. Again, denying services as an insurance company is not a good way to do business. The better way is to get them the treatment they need so that people are healthier. Most of the time when they're healthier, they're happier, most of the time. And when they're healthier, they cost less, which means we're going to make more money. So again, we want people to get those services, but not just any service. Services that we call medically necessary. And I'm going to get to what that actually means. What is a medically necessary service? And you hear that term thrown around a lot. It gets a bad rap, but I'll get to exactly what that means. We can make up rules on our own. In fact, most of the rules we follow, we didn't make up. We need to follow the rules of the federal government, and that is CMS, Center for Medicaid and Medical Assistance. CMS services give us specific guidelines we must follow. We also have to follow NCQA regulations, and of course, those from the state of Delaware. We want to decrease utilization. In other words, by getting people the services they need, We want to decrease some of those services. But what are the most costly services? I mean, actually, we're overjoyed when people see their PCP. Please see your primary care physician as often as you want. If you have an emergency, go to the emergency room. If you have the flu, don't go to the emergency room. If you have the flu and it's really bad and your doctor's not available, go to an urgent care center. If you need your physical for your sports, your high school sports team, don't go to the emergency room. So when we say decrease utilization, we want to decrease those services that are being used too much that people shouldn't be using. If you broke your leg, go to the emergency room. If you're bleeding profusely, go to the emergency room. These are we're more than happy to pay, please pay for that, go. But we want to stop inappropriate utilization of those services. We, of course, want to project a positive image. And we have this opioid crisis, and we're supposed to fix that as well. So the company wants us to fix the opioid crisis. What about the member? Again, we call them members. What about you guys? So for you, we need to provide all needed services. We need to make sure that if you live in Georgetown, if you live in Rehoboth, if you live in Kent County, if you live in Center City, Wilmington, all the services you need are available for you. How far away do you have to drive? How long is the wait time for you to go? We need to make sure that all of your services are available. That is something we are audited on a very regular basis. And we need to make sure that you can get what you need. We need to do geo-mapping to ensure that you have enough OBGYNs, pediatricians, psychiatrists, that they're all available to you. Now, you may not want to go to that doctor. You may want to go to the doctor who is in a different county. That's, of course, up to you. But we need to make sure that they're in your neighborhood. And that is a challenge. We do have some shortages of specific kinds of doctors and nurses in Delaware, actually across the country. And that's a challenge, but that is part of our job. We need to coordinate care. It is challenging to coordinate our healthcare system. We need to make sure that when you're juggling, well, where do I get this medication? And I have to see what doctor after this doctor, and I got to get physical therapy, and then I got to get, or if you have behavioral health issue, you're going to go to partial hospitalization, but you still need to see a psychiatrist for your medication, then maybe therapy. And how do you do all that? That's our job. We do that. We do that for free. That is something we are contracted to do, so we need to coordinate care. We need to ensure that the doctors you are going to are implementing evidence-based care. What does that mean? Well, that means that the care you're getting has scientific proof that it works. That's important. It is very dangerous when you get care that is not evidence-based. Number one, your condition can get worse. And number two, you will waste money. And it prolongs your healthcare issue. So we need to ensure that the care you are getting meets certain criteria and is evidence-based. Some people will tell you, oh yes, there's research that says eating tree bark will do. So there are certain places we go to ensure that that care is evidence-based. I can tell you that it is not up to us to decide whether it's evidence-based or not. We are not the deciders of that. We rely on organizations such as the American Medical Association, the American Psychiatric Association, and the American Psychological Association to tell us this is the best care for this type of disorder. We have to pay for services. So if your doctor sees you, we need to make sure your doctor gets paid. If you're following the news right now, you know that a large organization that helps send the bill to insurance companies, again, all insurance companies, had a cyber attack and interrupted the payment of services. We need to make sure that our providers, doctors, hospitals, nurses, therapists, physical therapists are all getting paid. Pharmacy are getting paid. And as any clinician you work with will tell you, we like to minimize paperwork. When you meet with your insurance company, you get stuff from your insurance company, I'm sure you get a lot of paperwork. It's annoying. Our job is to try to keep it as less as possible. That's our job to do, by the way. So let's talk about those medically necessary services. I mean, says who? Who says they're medically necessary? So if a doctor says, you know what, you have a splinter and I'm not sure how deep it goes, what we're going to do is run a blood test, an MRI, a CAT scan, and an X-ray. You don't need all that for a splinter, number one. And number two, those organizations that I just said a second ago, the AMA and the APA, et cetera, they would tell you you don't need that for a splinter. So when we say it's medically necessary, we're relying on those organizations to tell us it is medically necessary. And this is the protocol to get you better for that symptom. They set the protocols, not us. We use a company called Intraqual, and Intraqual was one of those organizations that was hit by the cyber attack that you might be reading about in the news. We use a company called Intraqual to help guide us on our decisions. Should we approve this? Should we not? If we don't approve a service, then we need to make sure that our member, that you, have another service available to you. That is very important. And we rely on the American Society of Addiction Medicine, in my field. They tell us what levels of care, what levels of service should be available in Delaware, and who gets approved for what. They set certain specific criteria for each of those different kinds of services. If we decide, you know what, I don't think we're going to approve this, based upon the information we have, we're going to deny the service. Well, just because we deny it doesn't mean that's the end. Your doctor, your clinician can submit an appeal, which means that they could say, well, wait a second, you didn't see the whole story, AmeriHealth. Please let me give you more information. And that's very important for your doctor, your nurse, or your therapist to do, is give us that more information. We always offer what's called peer-to-peer reviews, which is your doctor can call one of our doctors and discuss on the phone, here, maybe the paperwork we sent, or maybe you didn't see this. Maybe we didn't tell a good enough story. Let me explain why Jane needs this service right now. So peer-to-peer reviews are always available when we deny something that we say is what we call non-medically necessary. There's always a story or more information that can be told for us to change our mind. But sometimes we don't. But we always will try to then to get you the service you need. So let me give you some real interventions about what it is I do on a daily basis. In April of 2018, as I said, we were told by the governor, fix the opioid crisis. Okay. So the first thing we're thinking about is, well, the first thing we recognize is a lot of people were dying in Delaware from heroin overdoses. At the time, fentanyl was just beginning, but we saw a lot of heroin overdoses. We saw a lot of overdoses from OxyContin and other illicit or illegal opioid drugs. We came up with a multi-pronged approach to battle this. And one of those was to increase the availability of a medication called Narcan. Narcan is a medication that reverses the opiate overdose, reverses a heroin overdose, reverses the symptoms of the overdose. Typically, when somebody overdoses from an opiate, their breathing stops, their heart becomes very labored, a whole bunch of things can happen. Narcan reverses that. What we discovered, let me just continue here. We also wanted to make sure that all the providers in Delaware knew what the guidelines were for treating somebody who was battling an opiate use disorder, such as heroin addiction. And we wanted to make sure that people could get medication for that addiction. So we became very aggressive in ensuring that everybody had these three things. How did we do that? Well, the first thing we did was we discovered that there was a copay for Narcan. And if you're not clear, a copay is when you go to the pharmacy and you get a medication, sometimes the pharmacy will ask you to pay a little bit of money. We discovered there was a $3 copay for Narcan. And our feeling was, if you're addicted to an opiate, if you're battling an addiction to heroin, and you have $3 in your pocket, you're probably not going to buy Narcan. You're probably going to buy heroin. So let's get rid of the copay. We petitioned the state of Delaware to remove the $3 copay for Narcan. And in 2018, they did. They removed it statewide for all Medicaid members throughout the state. Narcan is free for anybody who's on Medicaid in the state of Delaware. In January of 2019, we then sent a bulletin to all of our providers who are working with members who have a substance use disorder, as well as our providers that prescribe opiates to members appropriately. People can take opiates for good reasons. People who have cancer or certain back injuries, sickle cell anemia, sometimes are prescribed opiates for pain management. So we sent them a bulletin saying Narcan is free. Please write a prescription for it. Please educate members, your family members of your patients on how to get Narcan. We made sure that everybody would have access to Narcan. And we flooded the market with Narcan, actually. We really got it out there. Also in April of 2019, we threw a free conference, completely free, in Delaware State University, in collaboration with Delaware State University, offering free CEUs for physicians and nurses and psychologists, social workers, and addiction professionals, talking about, here's what the research says on how you get better from an opiate addiction. I can tell you that nobody from AmeriHealth spoke at this conference. We were not speakers. That was important to me. Rather, we wanted experts in the field to discuss, here's how you get better from an opiate addiction. Over 280 Delaware professionals attended. It was a relatively successful conference. We also look at the pharmacy profile for anybody who fills Narcan more than once, right? So if you fill it once, you want to keep it just in case. If you fill it twice, there's the possibility you used it. And if you used it, that could be a clinical concern. So we want to look to see if somebody filled it more than once, are they in treatment? Is there anything else they need? It's reviewed with me. And then I send this to our teams to call these members. When we call them, we don't have a script. We don't say, hey, Mr. Jones, I see that you filled Narcan. Are you battling heroin addiction? Rather, we call and say, hi, Mr. Jones, it's AmeriHealth. Is there anything we can help you with? That's it. That's the whole script. Anything we can help you with. Sometimes people say, I'm hungry. I need food. Sometimes they say, I need housing. We have a housing problem in Delaware. Sometimes they say, F off, and they hang up on us. And sometimes they say, I need treatment, and we get them treatment. We also call any member who we can see had Narcan administered via EMS, via an ambulance, or the emergency department. And same script. Hey, Mr. Jones, anything we can help you with? Sometimes they hang up. Sometimes they say, I need treatment, and we get them treatment. So you see that since inception, 500% increase for prescriptions. That looks pretty good. This is what it looks like. So way there on the left of your screen, you're all getting really close to the screen right now, those of you who are still awake, you can see that not many prescriptions for Narcan. And then it starts to go up. Now, Tim's going to hate me for this. Can somebody type into the box, and Tim, tell me if you get any answers to March 20th. What is that? Look at that spike for March 20th. What is that? Anybody have an idea what happened?
No one's typed anything so far.
I put everybody to sleep, Tim. That's why.
Somebody said pandemic.
Yes, that is when the world ended. That is when COVID hit, and COVID hit Delaware hard. So all of the providers closed, and they were all given permission to create take-home kits for those members battling opiate addiction. They could take home certain medications like methadone or Suboxone, and we put Narcan in all of their take-home kits. That's what you're seeing. You can see that it goes up and down, but pretty steadily up for quite some time. And you see there, January of 2024. Now that little red symbol there, that is because for a while, Dr. Rattay was the director of the Department of Health for Delaware. There was a standing order. So even if you didn't go to your doctor for a script, you had one from Dr. Rattay. You can go to any pharmacy in the state and walk in and say, I need Narcan. And if you were a Medicaid member, they would give it to you for free. So we, again, track this very carefully. We look for, I unfortunately, not part of my lecture right now. The worst part of my job is I have to do investigations into any one of our members that died from an opiate overdose to see if, did they get Narcan? Were they offered treatment? Were they in treatment? What could have been done to prevent this death? It's the worst part of my job by far. And I do these, so far in March, I think I've done 5 of them. 5 of our members have died from an opiate overdose. Horrible part of my job. So again, we're tracking who's getting Narcan. We're tracking where are the bad batches, where are the batches that are spiked with something that is bad. Right now, as you're aware, we've seen the increase in fentanyl. Fentanyl is a synthetic that is about 100 to 100 to 1,000 times, depending upon the dosage, more powerful than heroin. A lot more overdosing on fentanyl. And right now in Delaware, we are seeing a drug called xylazine, which is mixed with heroin, which causes the medical term is necrosis, which is a destruction of the skin at the site of injection. Very, very dangerous. So these are the things we track to see what town is it in. If it's in this town, will it go to this town? And we're able to kind of geomap it to see where do we need to send our services to send people to help. So along with this, I'm not done that one intervention, that Narcan initiative. You're looking at buprenorphine, and this is a drug called Suboxone. It's medication for opiate addiction. And since we started calling people and saying, hey, can we help you? What you see is a steady increase in people getting medications for opiate addiction. Not only did we get Narcan out in the community, we actually got more and more people the treatment they need, the medication they need for opiate addiction. So that's an example of what I do on a regular basis, coming up with these types of interventions. Let me give you a few more before you totally fall asleep. So let's leave substance use disorder for a second and talk about kids. We're going to jump to the other end. Let's talk about kids. ADHD, you may have heard of it. Some of you may have it. It's unfortunately, very common, one of the most common disorders of childhood, diagnosed frequently in the preschool years, characterized by somebody with a lot of energy. Ratio 4:1 for males to females, attention deficit hyperactivity disorder, hyperactive type, 4:1 males to females. Attention deficit hyperactivity disorder, inattentive type, 4:1 females to males. Very important comment there. More males are hyperactive than females, more females more inattentive than males. Please note, it is not called ADD. There's no disorder called ADD. There's no, he's got inattention. It's attention deficit hyperactivity disorder, either hyperactive type, inattentive type, or combined type. That's what it's one of those. Often again prescribed usually by 7. Your parents know it, the teachers know it. As you see there, 6% of children and adolescents in the US meet criteria for it. We have over 400, probably closer to 600 kids who meet criteria who have a diagnosis of ADHD. Well, the American Academy of Pediatrics did this gigantic study years ago on how can we get people better with ADHD? Is there a clinical practice guideline we can come up with for the diagnosis and treatment of ADHD? How do we get them better? So they have a whole clinical practice guideline. In a nutshell, without me going through this clinical practice guideline, is a secret. It's a combination of medication and behavioral therapy. 2 forms of treatment, medication and behavioral therapy. Not just one, not just the other, both. Both have a very good effect working together on decreasing the symptoms of ADHD. All we did was send out a letter to the clinicians, not to the parents, not to the kids, just to the clinicians, saying, here's the clinical practice guidelines for treating ADHD. We just wanted to let them know this is what the American Academy of Pediatrics says. And what we found was a significant increase in providers implementing those treatments as designed by the American Academy of Pediatrics, just by us sending them, hey, by the way, here's what you should be doing to get Bobby better from ADHD. And we found that those treatments went up exponentially by providing that education. Let's think more outside the box. March 13th, 2020, I was in the office in Newark and they said, order your plant and leave. So I ordered the plant figuring I'd be back, left some food in my drawer figuring I'd get it, and I left. And I left for a long time. So maybe some of you remember those days. We were in our houses a lot. We didn't know when we were going to be able to leave our houses. We were scared going to the markets. The markets were running out of food. It was a crazy time. And then the state said, we got to get people treatment. We can't just leave them. I mean, we got to get them treatment. How are we going to do that? Well, telehealth was still pretty new. And if you were going to try telehealth, it was pretty expensive and you needed certain, per law, equipment to do it. So you needed HIPAA protected ways to engage in telehealth, a special kind of camera that transmitted things in a protected, secure way. But people didn't have that. And people didn't want to leave their home to go into treatment, into a therapist's office. So we had to relax the rules of confidentiality so people can engage in telehealth using their cell phone. So they can use, what's the Apple one? FaceTime or Facebook Messenger. These were never legal before March 2020, but we had to relax the rules, working with the government to relax the rules of telehealth so that they could use other forms of technology to see their provider, and not just behavioral health providers, any provider. We did that working with state government. Usually, as I talked about, when you go to see your therapist, your psychologist, you're going to sign a whole bunch of paperwork, right? You're going to sign consents. But during the pandemic, there was no way to do that. Now we have DocuSign. We have all kinds of ways to sign online, but then we didn't have that. So we had to come up with other ways for you to be able to give consent that the therapist could ensure he or she was meeting the law for consent and confidentiality. How can a therapist ensure that if they're doing a session with you, that you're in your living room and nobody's sitting next to you? What are we going to do about crises? Let's say you're doing telehealth and your patient says to you, your client says to you, I think I'm going to kill myself. You're miles away. Maybe you're in another state. We have to think about all of those types of interventions. And lastly, I'm going to point out medication-assisted treatment per DEA law required that the patient and doctor saw each other face-to-face in the same room for the prescription to be written. We had to work with the federal government to relax that law, to allow it to happen via telehealth. And we relaxed the laws so much to the point that even regular phone contact, without any face-to-face like we're having, just phone contact was billable. Clinicians could get reimbursement for it. They had to write a note, of course, and it was legal for them to do. So we had to really think about how is therapy done and how can it be done in this world where some people, they don't have these nice laptops with big screens and nice cameras. Some people have cell phones and that's all they got. Some people have just regular phones and that's all they got. How can we ensure that they can get treatment? So we did all of this in a few months, 6 weeks to implement, roll out, and educate everybody on how to do it and make sure that everybody was getting paid so they could keep the lights on in their office or pay their staff who are now home. So I am appointed by the governor to the Delaware Sex Offender Management Board, where I'm on the credentialing committee, and we decide when providers come to us whether they should be able to work with people who have committed a sex offense. So in meeting with other clinicians, I've gotten some questions about sexuality that are concerning. Such as Bobby has autism, but he wants to date. How do we stop that? What's wrong with dating? Dating is fine. Well, I didn't think with autism he should be able to date. Yeah, he can date. Jane has autism and she is interested in masturbation. We need to stop that. No, people masturbate. That's okay as long as they're in the privacy of their room and they're alone and then nobody's getting hurt and it's okay. Or what does that mean? How does that? So I kept getting a lot of these questions that were concerning. So we decided to host a conference for addressing some of those issues. I'm going to show you in a moment what those issues that we'll be addressing in the conference are. The conference is tomorrow at Delaware State University from 8:30 to 12 noon. It is free for all clinicians. We actually shut down registration for the conference because we hit our max. We have over 300 people registered for the conference, professionals from across the state. And it is, again, free, offering free continuing education for our providers in the state of Delaware. I know this is hard to see, but we're going to talk about what is a sex offender? What does that mean? How do we determine somebody in Delaware is a sex offender or is not, or this is the treatment they need, or will they get better, or do they need to be supervised for their entire life, or should they be locked up? So we're going to educate providers and state government officials and police officials about what is treatment and assessment and treatment for those who commit sex offenses. We are going to discuss those members with those Delawareans who have an intellectual disability or developmental disability and engage in sexualized behaviors. You can see one of our speakers is Ms. Stacy Watkins, Deputy Director of the Delaware Division of Developmental Disabilities. She's one of the speakers at the conference. So we want to talk about this is appropriate, this is not appropriate. These are the type of services that are available throughout throughout the state for these guys. And these are the people who don't need services. This is okay. So we have speakers addressing that. And lastly, it was shocking for me to learn, and I am sad to learn, that Delaware has a huge problem in human trafficking. Our Latino, Asian, Western African population in Delaware are especially susceptible to human trafficking. That's something I was not aware of. So we have Steve Eichel, Dr. Steve Eichel, a renowned expert in human trafficking, and Caroline Brittingham, who is our Deputy Attorney General. We will also be joined by a detective from the state police, Dustin Yeltsin, who will also be lecturing tomorrow on the multicultural impact of human trafficking in Delaware. So these are the type of things we need to come up with on how can we help our Delawareans in the behavioral substance use field. So I want to point out, I didn't come up with this on my own. If you gaze through this list of my steering committee, these are the people that I worked with to do this. You see, I'm last. These are the experts in Delaware. It's not me. These guys are brilliant. They're the ones who said, here's how we should put together a conference. Here's what we need to discuss. So they came up with it and guided us and put this conference together. And I am the last one on the list because I'm probably the least deserving on the list to be on the list. These guys were amazing. So what I do on a regular basis is collaborate. I collaborate with lots of organizations throughout Delaware. That is something Delaware excels at. We collaborate. That's how we do what we do. We can't do it in a vacuum. And when I started my lecture, I think I mentioned, we no longer view people as just behavioral health or substance use or physical health. We have to think holistically. And the only way to do that is to collaborate with numerous professionals throughout the state. So I'm watching my time. I'm going to go a little bit quicker. I apologize. I'm probably on slide 19. So know that I'm almost done. Other things that I have to do that are really hard. Research supported, but there's not enough evidence. So people will say like, well, I want to try this. You know, there's research out there that says this is good, but it's not yet evidence supported. Some hot topics, you know, I know I'll get in trouble for, I'm going to bring up anyhow. Ketamine. Ketamine is a drug that is showing a lot of research right now for major depressive disorder. A lot of research. Is it evidence supported? Well, the jury's kind of out, depends who you ask. Some will say, yeah, there's a lot of evidence. Some will say no. So that's a tough one. So we have to kind of decide, are we going to cover it or not? Neural feedback, if you're not familiar with that, that's really cool. If you have a Sony PlayStation and you play the Star Wars games where you put a kind of like Electra's a hat on and you can use the Force, that's basically neural feedback for ADHD. Really cool stuff. Does it work? Kinda, sorta. Should we approve it? Yeah, maybe. So that's another kind of thing I'm not sure. Do we approve it? Do we not? We kind of look at the research and have to decide. ABA, applied behavioral analysis, works great for kids with autism spectrum disorder. Does it work with conduct disorder or anxiety? Yeah, maybe. Should we approve it? I don't know. Not yet. If you're over 21, does it work? Maybe. I don't know. Again, I talk about not evidence, cheaper alternatives. You've heard out there right now, there's something called coaches. Well, coaches are certainly cheaper than psychologists. They're certainly cheaper than MSWs. Who should we approve? Should we pay one level more than another level? There's a lot of apps out there right now that promise, oh, you can get therapy from an app. Should we pay for that? AI is big right now. Should you get your therapy from AI? And if so, should we pay the developer of the AI? I don't know. So again, there's other examples there. Equine therapy is working with a horse. I like horses. Again, is that something we should pay for? And lastly, I'm going to end with, what about when we see a physician assistant that prescribes a lot of Suboxone to our members, but no other treatment? The doctor, the physician assistant, he could be a pill mill, or he could just be a good prescriber. Should I throw him out of the network? What do I do about that when I can see that the people that person is seeing is not getting any treatment but medication? So that's kind of the decisions I need to make on a very daily basis. I think that was my last slide. And I'm good that Tim, I believe I'm good. That leaves 8 minutes for potential questions if anybody is still awake. Tim, wake up. We lost him.
I'm here. I'm here. I was not fast enough on the draw. No, we've got questions. Thank you very much. All righty. Starting with, August wants to know, what do you like about Kent County?
So in particular, people have a misconception about Delaware. All Delawareans kind of look the same way. Kent is extremely multicultural. If you kind of go, Western Kent, you will find lots of different cultures. I love when Waze gets creative on me. There's barbecue places. There's great foods. There's different cultures throughout Kent and Sussex County. You may be aware or not, there's a large Haitian community in deep Sussex County. So in particular, what I like about Kent County is it is extremely multicultural. Dover is okay. I mean, I like Dover, I guess it's okay. I do like getting lost in the rural areas of Kent.
All righty. Do you work closely with the Helen F. Graham Cancer Center patients?
I do not. I do not in particular with that center. Again, so my office sits directly next to our physical health chief medical officer, Dr. Deb Allen, who potentially would, but again, I see the relationship to somebody who's, say, battling cancer. They need, just like when I talked about working on a cardiac unit, they have a medication regimen they must follow. And if they don't follow it, they're going to get sicker. When you follow that medication regimen, you might get sick. You might get nauseous. You might lose your hair. You might get very anxious. So you have a lot of motivation to not want to follow that treatment. It is important then that somebody has behavioral treatment with the physical health treatment so that they follow that regimen. Not only do you have all that, you may have had surgery, you may have had other treatments that affect your ability to have a relationship with a sexual relationship with your spouse. You might affect, maybe the treatment affects your memory. So again, I think for holistic care, it would be important to pair that physical health treatment with behavioral health treatment, especially with cancer patients, but with many patients.
Has the legalization of recreational marijuana made any of the addiction issues more difficult to treat?
Yes.
You can walk around Delaware and smell pot in public places, ...
Yeah, great question. So we're kind of in a quandary, right? Because the federal government hasn't legalized it, which means we can't pay for it. So medicinal marijuana is legal in Delaware, but we can't pay for it because the federal government has not legalized it, and we must follow rules of the federal government about services we can and cannot pay for. So that's quandary number one. Quandary number two, let's say Mr. Jones wants treatment and says, okay, I want treatment for marijuana addiction. If Mr. Jones wants that, we will certainly pay for it. If Mr. Jones says, I am battling alcoholism and I smoke marijuana, now marijuana is legal. I mean, they passed the law of recreational marijuana is legal in Delaware. They're in process of where you can buy it, et cetera, et cetera. Does that mean Mr. Jones has a problem? Does he have a diagnosis? If he says, I smoke marijuana every day, I like it. I don't smoke it when I drive. I don't smoke it before work. I don't smoke it when I'm with my kids. Does Mr. Jones have a problem? So that's a quandary, right? So The rules are still we're trying to figure it out. We don't have any hard, fast rules on this yet. Some states, again, have legalized recreational, some medicinal, some not at all. We're in an election year, so I don't know what the fallout will be from whichever way the election goes. Yes, great question. Huge quandary, not just for us, but also for your employer. Is it a problem? Is it not? Do you get treatment? Do you not? Great question. We're still trying to figure it out.
As a public health practitioner, I am still puzzling over, we fought such a fight to get rid of cigarettes, and then we turned around and legalized another combustible material. That's no commentary on my part about that it's marijuana. It just is endlessly fascinating to me.
Yeah,
ADHD and Zoom classes during the pandemic, tough combo. Did you work with the Department of Education during that time as well?
yes. And it was difficult. So not just for ADHD kids, for kids on the spectrum who are home, how do you do evaluations for ADHD? The parents who were suddenly finding themselves at home by themselves trying to get, so you notice I pick on the name Bobby. So now we're asking Bobby to sit in front of a laptop, maybe a 15-inch laptop for 6 hours. He's not going to do that if he has ADHD. Even if the parent says, well, we're going to follow every medication rule we can, he's not going to do that. So we talked about different behavioral techniques and scheduling parents can do. We talked about allowing those kids to have a staggered schedule. We talked about more take-home work that they could do that is outside of traditional hours. I'm blanking on who I worked with from the Department of Education. She was wonderful. But yes, I worked with the kids department and the Department of Education during that time to come up with alternatives for kids. Ultimately, of course, all of those rules are at the discretion of the Department of Education. But yes, I was on several panels at that time. And of course, Nemours. Nemours, one of the experts in the state of Delaware, so the expert on children, so worked closely with Nemours.
Right, right. So Amber asks, have you ever experienced a patient that has been addicted to a drug prescribed to them by a psychiatrist? If so, is there a way that your department can prevent this drug from being put out? And I'll ask, in addition, should your department be involved in saying no, a certain drug shouldn't be dispensed?
So great question. And one short answer is yes. So we'll see. Let me throw some examples out at you specifically. You may, for those of you who are older on the call, there used to be some famous rock stars, Tom Petty, Prince. Both of them died the same way, and they died because they took an opiate, a prescribed opiate, and they mixed it with a benzodiazepine. Benzodiazepine common ones are Valium or Ativan. And you mix that with an opiate, and it stops you from breathing. And that's how Prince died, and that's how Tom Petty died, because they mixed them. And we're able to see that. We, in fact, alert practitioners. We do alert them that, hey, your patient, Mr. Jones, is currently prescribed this and this. Now, they can say to us, yeah, here's why. And great, thank you, just happy you're aware of it. I see why you said here's why. If our director of pharmacy and or board certified physician feels that it's still a medical concern, we can report it to the board and another judicial group that works with the Office of the Inspector General to investigate the clinician. And we do that on a regular basis, daily basis, when we see patterns of prescribing that are concerning, not just American Health. Highmark does the same thing, Delaware First Health. That's something we all do. We track those types of medications very carefully, and we look to see what else is being prescribed for the member. We look to see, are they getting that medication filled by Dr. Jones and Dr. Smith from somewhere else and Dr. Thompson from somewhere else. So we look to see if they're doctor shopping and doctor hopping. Yeah, we can also lock somebody in, which is a way of saying, Mr. Jones, you were getting an opiate from Dr. Smith and Dr. Thompson. Now you can only go to CVS in Georgetown. That's the only pharmacy you can go to fill your scripts. and we will see exactly what you get only from that pharmacy. All other scripts will be denied. No other pharmacy in the state will fill it. We can do that as well, and we have.
Right. Well, sort of along the same line then, how do you combat pain medication addictions the same way as you do opioid and other drug addictions, or not? That's a loaded question. Go for it.
Same way, but when we talk about pain medication, so we have opiates, we have muscle relaxants, which are also extremely dangerous when combined with opiates or benzodiazepines. Same type of respiratory distress. So the same answer still applies. And when you say how do you combat that, we actually for members that are taking muscle relaxants and opiates at the same time, we alert their physician same way. Same exact thing. Actually, somebody who's taking, say, Flexeril and an opiate will contact their doctor and say, you're aware of this? And again, if their doctor says, yeah, but here's why, and here's how long I'm going to keep him on it, and then when then I'm going to stop him or titrate him down, okay, no problem. But we will contact the doctor and ask why. So yeah, same answer actually. Not a hard question. It's the same answer.
Okay. How does the field of behavioral health proactively address the potential stigma associated with seeking mental health treatment, particularly within specific communities?
So the first part of the question was an easy one because the silver lining of the pandemic, everybody's now anxious and depressed. Everybody is seeking treatment. It's no big deal anymore to say, yeah, I got anxiety. Yeah, no kidding. Everybody's got it. Oh, I'm depressed. Yeah, everybody's depressed. I mean, so that the one benefit of the pandemic was that it really lowered stigma in many communities, but not all. Certain communities that's still very big and a big issue. So how do we go about doing that? Well, I mentioned as an example the Haitian community in Southern Delaware. That community sees 2 doctors total. Those 2 doctors prescribe, not prescribe, provide all the services: behavioral health, substance use, physical health. That's who that community sees. So when we talk about how are we going to reduce stigma in that community, we work with the providers in that community. We work with those 2 doctors in particular to see how we can ensure that the people in that community have available the services they need. Cultural norms. Number one, it's not. I don't think it's my job to change cultural norms, so I'm not going to do that. But I'm certainly going to make sure that if somebody wants the service, it is available for them. But that is, stigma remains a challenge. One of the challenges we are focusing on right now in collaboration with the state is pregnant women who are battling an opiate use disorder and the stigma they have. Often afraid to tell their doctor, their OBGYN, they are battling an opiate use disorder. Often shameful, feel shame when they go to the doctor and say they need treatment, so they hide it as long as they can. So we are working on reducing stigma by working with behavioral health agencies and partnering them with OBGYNs throughout the state to talk about ways to communicate available treatments to increase the availability of those treatments.
All righty. So occasionally I will do a little ad lib myself on a question, so be warned, I'm about to do that. Kathy asks, I was not expecting that dispensing Narcan would be considered a behavioral health intervention. Is addiction considered a behavioral health challenge rather than an illness, as some refer to it? And my ad lib is, in my world, Narcan is considered a life-saving intervention first, to be followed ideally with a behavioral health intervention. But anyway, the floor is yours.
No, I agree. It's not an intervention. It's a methodology of keeping somebody breathing. The goal is to get them treatment. It's an intervention in preventing death. That's really all it is. Narcan does not treat opiate addiction. It treats respiratory distress. And that's pretty much all it does. There's a big debate as to whether it's enabling. If we give Narcan out, and you've heard what are called fallout parties, so people will gather together, shoot heroin, and there will be one guy who does not shoot heroin. He walks around, or she walks around, giving Narcan to those who appear to have overdosed. And then they'll take turns as to who is the person who's, on Narcan duty. Are we enabling? Again, my feeling is keeping them alive at least gives us the chance of getting them into treatment. If we don't give them Narcan, they'll die. So that's a tough one. I met with a director of a hospital in 2020 regarding giving Narcan to patients. And the director of the hospital said to me, "What about pregnant women?" And I said, "What do you mean?" And he said, "Well, there's no research on giving Narcan to pregnant women." I said, "Okay." And he said, "So I don't think we were going to do it because it's not been FDA approved to give to a pregnant woman." I said, "Well, then you're going to have 2 dead people on your hands as opposed to 1 dead person." I mean, I don't understand the question, but he felt since there wasn't research, I mean, again, at this point, when you're administering Narcan, that person is most likely not breathing, and CPR is not going to work. But
Right.
that director of that particular hospital felt since there wasn't enough research, they weren't going to give it to pregnant women who were overdosing. Okay. I
All
just
right.
want to make it available.
Well, and that, assuming the mother's life is preserved and the baby's life is preserved, the baby is going to be born with addiction issues anyway that will need to be
At
managed.
least alive. I mean,
Yeah, but at least alive. Yeah, that's disturbing. A couple of quick questions from August. August, are you always ask interesting questions? What was the one thing that you would change in your career, if anything?
I never thought I'd go into administration, so I enjoyed working with kids. I was an evaluator. I was relatively good evaluator, relatively. Um, I never, when I never worked behind a desk. I didn't sit behind a desk. When I did my evaluations, if they were young kids, I sat on the floor. And that's sat cross-legged on the floor across from them. We drew, we played with Legos, and I'd get them to talk. And then somebody pushed me to administration, and I stayed with administration and then kept going in administration. And now I don't see kids anymore. Started going to court, and that was fun. But working with kids was enjoyable and rewarding. So I probably miss working with kids. It was
All right. So in the same vein from August, how do you recover from making a bad decision?
I make them daily. I make bad decisions every day,
Amen.
all the time. All the time. I work with an amazing team of people. That's how I work with a team of people. We fix it. If I can fix it, we fix it. I work with a great team of people. And then you move on. So my wife tells me in terms of my forensic work, not to tell some of the stories because they're very disturbing. I have a good friend who works ICU at CHOP in the cancer unit. I say, "How do you do what you do?" And he says, "Well, how do you do what you do?" So how do you keep going? How do you keep going when a bad event happens, when somebody overdoses or when somebody kills them, via suicide? How do you keep going the next? You keep going. Rely on your network, your social support system, as well as your peers, your professional support system, and you keep going. As I said, the worst part of my job is when a bad batch hits Delaware and I have to investigate a death. It's awful. It's just terrible. But
All right.
keep going.
Is Delaware seeing a lot of crystal meth use and overdoses? Does AmeriHealth connect members with orgs that provide other SUD harm reduction tools like xylazine or fentanyl test kits, safe smoking kits, etc.?
Yeah, so we don't provide, so backward answer, we don't provide the test kits. We don't provide any, we don't provide the Narcan. We can tell people where to get them, but we don't actually provide them. We're not allowed to do that. So there are those test kits. The DMMA and DSAM are providing those. You can get them. We do provide information where you can find those. We ourselves do not provide it. We're not allowed to. Meth, yeah, in Sussex, actually. Strangely, in southern Sussex, there's a huge increase in methamphetamine usage. not as much in Wilmington, not as much in Dover. Southern Sussex, huge increase in meth. We are hearing reports of gangs of Bloods and Crips, actually, strangely enough, and Latin Kings in southern Delaware, in the rural areas of southern Delaware. That's where.
All righty. It's funny, I just answered a question and accidentally closed it, so I'll have to go backwards. In regard to Delaware's aging sex offender population in prison and their release because of their level of care is too complex for jail, but nursing homes often don't want them. What can we do?
Ooh, that was somebody out there is, that's a good question. That's no young high school student. So what can we do? That's a huge problem when that person seeks treatment, hypothetically gets treatment in an inpatient hospital and then needs discharge. Where can they go? There's one shelter in the state of Delaware, to the best of my knowledge, that will accept a sex offender, that shelter being in Dover. There is an extreme lack of housing facilities for sex offenders. So that's a huge problem to ensure that they have access to treatment, and treatment including a house. It's a huge problem. There's other areas that I'm not going to mention the geographic areas during this call that allow for registered sex offenders to move to in Delaware. I'm not saying we send them there, but there are certain areas we know geographically in Delaware that will allow sex offenders to move to. Huge problem. One that is actively discussed. I'm on 2 committees actually that discuss that right now. Huge problem. I don't have a good answer for you.
Right. Okay. And then I'm going to rephrase this question a little bit. So I believe I heard you reference at a national level who's our next president, and at a local level, who's our next governor, and that's very roughly paraphrasing.
Yeah, I want to stay neutral.
Yeah, it sets the stage. Do you have a sense of where we're going on the recreational legalization of marijuana in Delaware and or nationally? Just an overall, it's a dicey question.
It was legalized. Recreational marijuana has been legalized in the state of Delaware, signed by the governor. There is a secretary overseeing that process, Secretary Coop. Rob Coop, I believe, is overseeing it, and he's excellent. I think he ran Homeland Security for a bit. So I think he's in charge of the Department of Recreation. I don't know what they call the department, but he's setting up the rules and regs for it. So that's Delaware. Pennsylvania will probably legalize recreational marijuana shortly. New Jersey has. Maryland, I don't know about Maryland. I don't know. So Maryland's in a 12 states, at least 12 states. So I can't really report on where they are nationally, where the movement is. I don't really have a comment on that. And my comment earlier regarding depends on the presidency. I don't want to. I want to stay as neutral as I can regarding political affiliation and your political beliefs. To the best of my knowledge, the 2 likely candidates for each party have differing views on recreational marijuana. So that may change. And again, we have to follow the federal rules regarding that. So whoever's in charge of the federal government is who we follow.
Right. So a last question, and then I have one, I think. Oh no, another one popped up. I have heard of an increase in the research on psychedelic drugs for the treatment of PTSD and addiction. Does it look promising?
I'm sorry, what was the last part of the question?
Does it look promising?
Yeah. Psilocybin, huge, lots of research on PTSD, and MDMA, commonly street name ecstasy. Yeah, PTSD, anxiety, depression, as well as psilocybin, which is commonly street name shrooms. Yeah, huge research. looking forward to the research. And if the FDA says, yes, this is approved, then we'll cover it. Really for us, covering it involves what the FDA says. If the FDA says it's evidence-based. And again, just because the FDA, by the way, I just want to clarify that last comment. The FDA can approve something as doing no harm. That doesn't mean that they're approving it and you should take it. It means that they've looked at it and it does no harm. Them approving it and saying this will treat this effectively is a different story. So we follow certainly what the FDA says. So yeah, psilocybin and I just psilocybin and shrooms and MDMA, yeah, are showing huge promise for the treatment of anxiety and PTSD, depression. Yeah, as is ketamine. Just waiting on kind of the final. See what they say.
Right. Yeah, well, it's been interesting to watch over the decades. Ketamine, a drug frequently used in veterinary medicine and then recreationally, and you've heard about people falling into K-holes, and
Special
now
K.
it's
Yeah,
Special K. Yeah, it's and now it's a potential solve.
Yeah, but again, for that, it's supposed to be used for people with severe major depressive disorder where other treatments have failed.
Right.
So, when people are like, "Well, I'm sad. I want an approval for ketamine." You should have already tried 3 bouts of therapy, 3 different kinds of SSRIs, or have had some clinically contraindicated reason why you couldn't have an SSRI before you would even consider ketamine. It is not a first round type of treatment. So frequently we get requests for Mr. Jones has depressive disorder, not major depressive, just depressive disorder, and needs ketamine. No, that's not how
Right.
it's not how the research suggests it should be used.
Right. So someone asked, I work in the restaurant industry and we have had people come in and provide us with a kit. Is the increase in doses you mentioned earlier the reason? And I assume the kit is the Narcan kit.
Yeah. So 1 dose of Narcan will potentially work on heroin, won't touch fentanyl. So 2, 3, sometimes 4 doses of Narcan before and sometimes that won't even work. We're seeing other forms of medication of severe, much stronger opiates. Some briefly showed up in Delaware and then disappeared. Some 1,000 to 10,000 times stronger than heroin and fentanyl that have gone to other cities. We do track those very carefully, and fentanyl wouldn't touch them. They're opiates, and just fentanyl wouldn't do anything.
Right. All righty. Well, thank you very much. I will call you Jordan as you requested. Very interesting talk. Lots of great questions. Everybody, we will see you next week. Thank you.
Thank you for your questions and time. It was an honor to speak to you today. So thank you.
Great.
Thanks, Jordan.